Now let's review influenza. So you might be wondering, when should you give antiviral medications for patients that are infected with the influenza virus? Well, this is recommended for the treatment of influenza only within 48 hours of symptom onset. However, if the patient has severe cases of the disease or they are in a high risk patient population, then antiviral medication should be provided regardless of the duration of symptoms. The drug of choice for the treatment of influenza A and B during pregnancy is oseltamivir. However, other medications such as baloxavir is not recommended during pregnancy, but they can be used in patients older than 12 years of age. The main takeaway I want you to get from this slide is that antiviral medications are indicated only within 48 hours of symptom onset, except for high-risk patient populations and patients with severe symptoms. The drug of choice for treating influenza in pregnant patients is oseltamivir. Knowing when to do an X-ray imaging of the ankle, the knee, is usually followed by the OTTAWA rules. Let's review the OTTAWA knee rules. So, imaging of the knee may be indicated if the patient is older than 55 years old, if they have an inability to bear weight for 4 steps, both immediately after the injury and at the time of the exam. Also, if they have an inability to flex the knee to 90 degrees, if there's tenderness over the head of the fibula, or isolated tenderness to the patella without other bony tenderness. So if any one of these are present in a patient, then you want to go ahead and do imaging. Another common topic is ADHD. A high-yield point that I want to bring to your attention is that in preschool children aged 4 to 5 years, they should be initially managed with behavioral intervention. However, you can start pharmacologic medications at age 6. So you can use drugs such as methylphenidate or atomoxetine. Electrolyte disturbances are another high-yield topic, but something that's more nuanced that you need to know is that if a patient has a parathyroid hormone independent hypercalcemia, this can be due to vitamin A toxicity. So recall that you have vitamin A analogs such as those used to treat acne. The excessive intake of vitamin A is associated with various effects, and this can include bone resorption and hypercalcemia. So some sources of vitamin A include animal sources such as fish and liver, and also dairy and eggs. Adrenal insufficiency. So you have primary and secondary adrenal insufficiency. Primary adrenal insufficiency is a disorder characterized by the loss of adrenal gland function, leading to the deficiency of aldosterone and cortisol. Primary adrenal insufficiency is mainly due to autoimmune causes. And these patients can present with symptoms of fatigue, weight loss, nausea, vomiting, abdominal pain, joint pain, salt cravings, or even adrenal crisis. Physical exam would reveal skin and mucosal hyperpigmentation. This is due to the increased production of POMC, a prohormone that is cleaved into ACTH and MSH. They can also have hypotension and vitiligo. So, while primary adrenal insufficiency is due to something being wrong with the adrenal gland itself, for secondary adrenal insufficiency, this is characterized by a decreased secretion of ACTH by the pituitary gland, leading to adrenal insufficiency. Some risk factors for secondary adrenal insufficiency include chronic opioid use, exogenous steroid use, and traumatic brain injury. They can also present with the similar symptoms and signs that I mentioned before, such as fatigue, weight loss, weakness, hyperpigmentation, and hypotension. A test that you should know about is the ACTH stimulation test. This is the most appropriate confirmatory test for suspected adrenal insufficiency. If a cortisol level is drawn 1 or 2 hours after administration of ACTH is inappropriately low, then adrenal insufficiency is confirmed, and then further evaluation is needed to determine the exact etiology. A 21-hydroxylase antibody level may indicate that adrenal insufficiency has an autoimmune cause, but it doesn't confirm the presence of an adrenal insufficiency itself. Cushing syndrome refers to the manifestations of chronic hypercortisolism. And you have two broad categories of this condition. The exogenous type is typically iatrogenic exogenous glucocorticoid administration, while the endogenous type may be due to adrenal glucocorticoid overproduction, ectopic ACTH overproduction, or pituitary ACTH overproduction. So Cushing's can be ACTH dependent, which is most commonly due to a ACTH secreting tumor, or ACTH independent, which may be due to cortisol overproduction. These patients present with symptoms of decreased libido, oligomenorrhea, depression, and psychological changes, proximal muscle weakness, acne, excessive hair growth, symptoms of diabetes, and even weight gain. Physical exam may reveal muscle wasting, central obesity, hypertension, hirsutism, purple striae, moon phases, buffalo hump, and hyperpigmentation if there is high ACTH. The skin may also bruise easily. So in patients with Cushing syndrome, you can do a dexamethasone suppression test in which the morning cortisol is tested after administration of dexamethasone the previous evening, and are used in the evaluation of suspected Cushing syndrome. Inappropriately elevated cortisol levels are indicative of Cushing syndrome. Now let's review non-alcoholic fatty liver disease. So the highest risk factor for this condition is obesity. This is extremely high yield. So remember, the number one risk factor is obesity. Other risk factors include type 2 diabetes and metabolic syndrome. There's also evidence that conditions like HIV, hypothyroidism, PCOS, OSA, and genetic variations of the PNPLA3 gene are also likely risk factors. This condition is usually discovered with an incidental finding of elevated liver enzymes. So if you see that they have an AST-ALT ratio of less than 0.8, it's more likely due to non-alcoholic fatty liver disease. However, if this ratio is greater than 1.5, you need to be suspicious of excessive alcohol use. So if you're suspecting non-alcoholic fatty liver disease, the first thing that you need to do is obtain a detailed history, particularly for alcohol use and hepatotoxic medications. Can you think of some hepatotoxic medications? If so, leave them in the comment section below. But some drugs that can be of concern include corticosteroids, aspirin, amiodarone, and valproic acid. So after you've taken that detailed history and examined for hepatotoxic medications and alcohol use, the next step is to evaluate for hepatitis B and hepatitis C infection. You also need to measure the ferritin and iron levels, lipids, and a fasting glucose level or hemoglobin A1C. If these blood results are negative, then you can do an ultrasound of the liver to see what is the cause of this non-alcoholic fatty liver disease, or if there are any underlying associations. So there are times when patients want to do home deliveries or home births, but there are certain scenarios where you need to encourage hospital deliveries. So if the patient is a prima gravida, has had a previous cesarean delivery, multiple gestation, fetal malpresentation, or pregnant patients at greater than 41 weeks gestation, then definitely encourage a hospital delivery. Now let's do a quick heme review. Chronic alcohol use is one of the most common causes of macrocytic anemia. If a patient is anemic and they have a normal peripheral smear and reticulocyte index less than 2%, this may be related to a nutritional deficiency or alcohol use. So if you notice that patients have low B12 or low folate levels, then you need to go on to do a homocysteine and methylmalonic acid levels. Do you remember what happens to these homocysteine and methylmalonic acid levels in vitamin B12 versus folate? If you do, leave them in the comment section below. Again, this is another high yield concept. So for anemia of chronic disease, it is typically characterized by a normocytic or microcytic anemia and a low reticulocyte count. However, if a patient has a reticulocyte index greater than 2%, you want to consider blood loss and hemolytic anemia as possible causes of this finding. So let's say that a patient is being treated with an ACE inhibitor, and then you note a increase in their creatinine by more than 50%. Well, in this case, you want to consider renal artery stenosis, which is a high yield cause of resistant hypertension. So in patients with renal artery stenosis, you need to do a CT angiography, renal artery duplex ultrasound, or even an MR angiography to diagnose this condition. Other causes of resistant hypertension include hyperaldosteronism, which is diagnosed with renin and aldosterone levels. Thyroid disorders as well, which is diagnosed with TSH levels. Cushing syndrome, which can be diagnosed with 24-hour urinary free cortisol. And FEO as well, which can be diagnosed with 24-hour urinary fractionated metanephrines and normetanephrines. Oral lesions or lesions in the mouth are commonly tested. Let's go through some of them. Herpes gingivostomatitis is primarily due to primary HSV-1 infection, and it is treated with antivirals such as acyclovir. Behçet syndrome, I'm sorry if I'm not pronouncing that correctly, but that is inflammatory in nature with oral and genital aphthous ulcerations, and it is managed with topical or systemic corticosteroids or colchicine. Hand, foot, and mouth disease is typically managed with supportive care. Vincent's angina is a bacterial infection of the gingiva associated with poor hygiene, and that is treated with systemic antibiotics such as metronidazole. If a pediatric patient presents with tenderness at the insertion of the patellar tendon at the tibial tubercle, you want to suspect OSGOOD-SCHLATTER disease. The diagnosis is based on history and exam, and initially imaging is not needed. So if you're treating this patient and their symptoms persist, or if they have any atypical features or a history of trauma, then imaging would be appropriate. Plain film radiography or an ultrasound would be a good first step for imaging. However, ultrasound has an advantage because it has no radiation exposure, which is something that we always aim for in the pediatric population. Distinguishing between erythema migrans and erythema multiforme can be a bit confusing. Erythema migrans is the rash seen in acute Lyme disease, while erythema multiforme is related to a viral or mycoplasma infection, or it can be associated with certain medications. How I remember it is that Lyme disease is due to a tick, and like the tick migrates from like a hiking trip to our skin. So that's how I remember erythema migrans, because migrans kind of sounds like migrates. So that's how I remember erythema migrans is related to acute Lyme disease. For erythema multiforme, it can be caused by or has a multitude of causes. So I use the multi in multiforme to remember that. And I correlate that with the viral infection, the mycoplasma infection, the medication reaction. So remember that the erythema migrans rash, that's commonly described as a bullseye rash. So that's very high yield to know. Knowing how to interpret the different changes in lung volumes and lung capacities is also high yield. If there is a decreased FBC, this indicates a restrictive pattern, while a reduced FEV1 FBC ratio indicates an obstructive pattern. Very, very high yield. If you want to see a higher review on how to interpret the spirometry findings for obstructive and restrictive lung diseases, and let me know in the comment section below. Also, if you're liking this content so far, please be sure to pop the like button, hit subscribe, and that notification bell so that you never miss another video like this. Let's go through another topic, and that is Kawasaki. This is an acute febrile medium vessel vasculitis, and we can remember it with the mnemonic crash and burn. C for conjunctival injection, R for rash, A for adenopathy, S for strawberry tongue, H for hand and foot rash, and burn for fever, of course. So this is typically seen in children less than 5 years of age, and it's more common in those of Asian descent. Risk factors include a family history and being of Asian or Pacific Islander descent. For symptoms, we already discussed them in the crash and burn mnemonic. Also, they may have a fever, a high fever for 5 days or more, and arthritis. The conjunctival injection mentioned is typically bilateral and non-purulent, and the rash is typically described as an erythematous morbilliform rash. I mentioned one of the oral mucositis signs that they can have, which is a strawberry tongue, but they may also have red cracked lips. And asymmetric cervical adenopathy. A high fact that you must remember is that all patients with Kawasaki disease should undergo echocardiography because they have a high risk of coronary artery dilation and aneurysm associated with the disease. So the treatment of Kawasaki disease includes both IV immunoglobulin and aspirin. So IVIG is indicated for all patients, and it also prevents coronary artery involvement. High-dose aspirin is also indicated for all patients. So initially we start with a high dose with a subsequent switch to low-dose aspirin. It's very important that we continue aspirin if coronary artery abnormalities are present. It's discontinued only if imaging confirms that there are no coronary artery abnormalities weeks after the onset of Kawasaki's disease. Anticoagulation may also be indicated for patients at risk of thrombosis or patients with thrombocytosis. These patients may also need vaccinations. So recall that the use of aspirin is typically avoided in children because of the third complication, which is Reye syndrome. However, in Kawasaki disease, of course, aspirin is an indication in these patients. But if you give them vaccinations, this helps to prevent viral infections while on aspirin therapy. Because if you have a viral infection while taking aspirin, this significantly increases the chances of children developing Reye syndrome. But the big takeaway I want you to think about for Kawasaki's disease is that the third complications are cardiac sequelae. So that includes the coronary artery aneurysms, which can be seen in up to 25% of patients that may lead to death, as well as myocarditis and myocardial infarction.